All right, thank you. So let's start off with my world is closing in. I have no financial interests or relationships to disclose. So this is a story about a 44-year-old Caucasian female clerk. She presented with progressively blurred vision over a period of 9 months. She basically wears a pair of glasses only for computer work. Difficulty seeing at night was one of her complaints, and she denies any shimmering lights, and there was no associated headaches or eye pain. She went to go see her optometrist and wasn't able to refract to 20/20. She kind of let it go and then came back again in about 6 months, and her vision declined to 20/40 in the right eye, 20/70 in the left eye. At 7 months, it became 2100, and then at 9 months, it was 2400. Her past medical history was significant for bilateral carpal tunnel syndrome, obesity, a colon polyp. She had appendectomy at the age of 9, bilateral arthroscopic knee surgery. Family history was non-contributory. She was a non-smoker, occasionally had a drink now and then, and she was on antibiotics for sinusitis and also birth control. No known drug allergies. On review of systems, she complained of occasional headache, but she denied all of the following: numbness, weakness, weight loss, decreased appetite, night sweats, fatigue, skin rash, cough, shortness of breath, hemoptysis, bloody stool, hematuria, joint pain, or low back pain. On exam, her visual acuity was 2400 in both eyes. Her color vision was depressed, 3.5 out of 14 plates in the right eye and 3 out of 14 in the left eye. There was no relative afferent pupillary defect, and confrontational fields, she had difficulty identifying my fingers in the periphery. The slit lamp was unremarkable. The posterior pole exam, the cup to disc ratio was 0.3, no pallor was noted, and on the macular exam, there was some subtle RPE changes with the loss of the foveal reflex. No bone spicules were seen. So here's her visual field, 24-2, and you can see that there was some severe depression of her visual fields. For those of you who have 25, 2015, 2010 vision, it's about minus 28, minus 31 in the mean decibel depression. Next set of tests was the OCT of the macula. And the OCT of the neurofiber layer is not shown. It was good. It was all green. And on the OCT of the macula, we find here some thinning of the foveal and parafoveal area. And you could see that furthermore on these horizontal scans in the area that you can see from the loss of the outer segment, inner segment junction along the foveal parafoveal region in both eyes. So, what's the next step? Do we order blood tests for infectious inflammatory etiologies? I'm a neuro-ophthalmologist, so most likely, if the MRI scan wasn't done already, I'm going to order the MRI scan. How about those of you out there who use the ERG? It may take a little bit of time, but that's something else can be very helpful. Yes, I know. Sometimes you hear hooves, you don't think of zebras, but I'm a neuro-ophthalmologist, so I'm going to think about the zebras. And hey, what's the thought of getting some anti-retinal serum antibody testing? And of course, if you're not sure, you go for the $1 million workup and you throw in the kitchen sink. So that's the ARS question. Go ahead and ask away or answer away. All right, so, wow, everybody wants to get the ERG, 43%. And not everybody was thinking about the zebra. So, when you're posed with a question like this, such as at my clinic, it's always nice to have next to you a panel of 4 people. So I have these guys with me all the time. They're on my phone. So I go, Randy, Valerie, Joe, Tony, what do I do? And then I come back in and tell them my thoughts to the patient. So what are your thoughts?
I'll just start out that when you see something that's this bad as far as the vision findings and the objective clinical findings are not so bad, usually that's a bad process going on. I mean, you can think about things like malignancies or compressive lesions, but with this, where you have the OCT evidence that there's retinal damage here as well, you're thinking that there's some sort of bad retinopathy that's producing this bad visual loss without obvious findings otherwise.
You realize we don't know the answers of those cases, okay? We were kept in the dark. And I find it very interesting that in the neuro-op sub-day, the main choice is an ERG and not an MRI or anything else. And it just emphasizes that the first step when we see any patient is to try to localize the process before we go fishing and before we get just test right and left. And unfortunately, in my daily neuro-ophthalmology practice, I spend more time telling people they do not have a neuro-ophthalmic disorder than making diagnosis of neuro-ophthalmologic disorder. So indeed, in a situation like this, I would remain very open-minded. Yes, of course, it could be potentially intracranial, it's relatively symmetric. Yes, of course, it could be optic nerve, bilateral progressive optic neuropathies. I would be very surprised to have something that starts by the periphery with only relatively delayed, profound visual acuity loss, central visual loss, unless it's glaucoma or papilledema, which we know this patient does not have. And this makes me want to go look at the retina very carefully. And I keep retina in my differential diagnosis until I'm sure it's an optic neuropathy. And here you're really handing us the case because Magic OCT has allowed neuro-ophthalmologists to become as good as retina specialists, correct? The only thing we can do is surgery, retinal surgery. But otherwise, medical retina, thanks to the OCT, has made us quite good. And so completely agree with Tony, completely agree with looking deeper into the retina at this stage.
Let me say, you mentioned about being in the dark. Recall one of her initial symptoms was difficulty seeing at night, and that alone tells you it's almost certainly retinal. So.
The way I would approach this is not only because she's having trouble seeing in darkness, but what's so worrisome is the pace of how this worsened. Because if you have someone in the mid-40s that has dark adaptometry problems or dark adaptation, and they have thinning of the outer retina, you're thinking retinitis pigmentosa or vitamin A deficiency, but those are slow processes. And when you have something affecting the outer retina bilaterally, this severe and at this fast pace, that is a huge red flag.
Yep.
Thank you. So after 5 minutes of FaceTiming all of my colleagues, I walk back into my clinic and tell the patient the results. So here we go. So the blood testing workup was unremarkable for infection inflammation. The MRI brain did show some mild right maxillary sinus mucosal thickening for which he was taking antibiotics for. And the ERG was abnormal with severely diminished A waves and B waves. There was an MF ERG that was ordered, however, it was not completed. At this point, we further then actually did set out for the SEBRA. And her anti-retinal serum antibody testing returned a Western blot that was positive for multiple bands at 23, 35, 46, and 60. It was unclear from the results if there were any confirmatory immunohistochemistry that was performed on retinal tissue. So, for the panel at this junction, seeing these patients having this type of result, do you coordinate yourself getting this paraneoplastic workup? Do you ask the primary care doctor to do it? Do you ask the oncologist? How do you guys go about that?
Yes, to all. It really depends on what you want to do and who you're working with and where you're working. We need, this is really typical of a paraneoplastic process, and you need to be aggressive in the workup, as Randy Carden mentioned. This is bad. It's going way too fast to be a degenerative process. At my institution, what I would do is order a full-body PET CT and send the patient to a good internist at the same time. Because no matter what, I need a good general exam, and I am not going to do it in the ophthalmology clinic.
Yep.
What I do is I actually get on the phone and call the oncologist. Because if I found that if I just refer this patient without any explanation or any talking to the person, they don't understand the gravity of the situation and how high risk there is that that person has an underlying cancer. If they just go to their family practice doctor or an internist and they examine them, they don't have the concept and the perspective that you would have to know what this is such a high likelihood of cancer. So I always pick up the phone and actually impress that upon the oncologist.
So I agree. I think I try to push the workup forward. I get the blood work the same day, and I get a CT chest the same day, because if it turns out to be positive, then immediately you're on the right course.
The audience is asking about the sensitivity and accuracy of the antibody testing and how that plays into your further evaluation.
So most of the testing is done at Oregon now, and there's two parts of it. There's a Western blot, which is looking for those particular molecular weight proteins, and also an immunofluorescence test where they take the blood and layer it on monkey retina to look for specific binding. And the problem is that some retinal diseases can cause antibodies. And so it doesn't always mean that it's a cancer. There can be an autoimmune phenomena, and some people have antibodies without cancer. And so you have to keep that into consideration.
Right.
But the clinical picture of this patient, that type of profound, very fast-paced visual loss, kind of tells you that it's almost just confirmatory in this case.
So on her workup, as you can see, it was a negative mammogram, negative pap smear, CT of the abdomen and pelvis was also negative, and unfortunately, there was small cell lung carcinoma that was found that was later biopsied and proven on the CT scan of the chest. So we have the diagnosis here, the cancer-associated retinopathy CAR syndrome. In follow-up, the oncologist treated her cancer, and this is where I'd be very interested to see what the expert panel says with regards to treatment for the CAR syndrome from the neuro-ophthalmologist, ophthalmology, retina standpoint. She received 1 gram IV daily of methylprednisolone for 3 days, and another cycle was repeated 4 weeks later. And I'll also be curious, too, to see what the panel says about repeating the anti-retinal serum antibody test from a different laboratory, which was actually done for this patient, and it was confirmatory for recoverin, which is the most common antibody with CAR. So, panel?
We have not had the greatest success with getting positive visual results from these patients. I mean, treating the primary cancer is important, and that may result in some improvement. We do give them steroids, and we think of other immunosuppressives as well, but at least in our experience, the results have not been that great for visual outcome.
I agree with Tony, yeah.
The biggest dilemma is you've got a patient with cancer, and you want their immune system to be fighting their cancer too. And so do you suppress the immune system when you might be turning the tables against them in terms of the response to the cancer? And this is, if you talk to oncologists, neuro-ophthalmologists and retinologists, this is all the big problem, is that what is the role of immunosuppression in this setting?
How far do you chase this? If the antibody testing is positive, but the workup, the imaging is negative, what do you do at that point?
Then you're in a surveillance mode.
Yeah.
You're going to have to redo that periodically and warn the patient and have them on the lookout for other symptoms. So you're not out of the clear at all.
So the paraneoplastic retinopathy falls under the general category of autoimmune retinopathy. So if you do the workup and you don't find cancer, and you believe that to be an accurate workup, then you still subsume it under autoimmune retinopathy. And I think repeat surveillance is important in some patients. So the first volley of tests being negative doesn't mean you shouldn't repeat it, and that's particularly with the PET scan, I think.
No, the tumor can be very, very, very small, below the detection level of any imaging test we have. So you have to be extraordinarily cautious, not reassured at all by an initial negative workup. And this is when indeed the involvement of an oncologist and very thorough follow-up becomes absolutely essential, because the vision may not improve, but it's a matter of life and death. And this patient is 44 years old. You'd better find the primary cancer. There are autopsy studies that have shown that some of those cancers are so little that they are only discovered years later on autopsy.
That's right.
And so it really can be very small.
There's one extra point. I think it's been alluded to, but maybe just for emphasis. At some institutions, it takes a while to get an ERG. You do not want to delay the workup here for the result of the ERG. With this history of subacute, widespread retinal dysfunction, assuming there isn't a drug responsible for it, then it's definitely autoimmune type pathology, and you have to go down the search for a cancer, regardless of whether you have the ERG result initially, right? I try to get them as quickly as possible, but I would still do the same thing with the CT scan and blood work right off the bat.
All right, thank you for this wonderful discussion. Thank you, Dr. J.
Thank you.
Appreciate it.